Okay, I think we're technically ready. Technology too. Okay, awesome. So I'm sure we're going to have a few more folks join us as we're just at 12:15, but we'll go ahead and get started. So I want to thank Dr. Kate Watson and Dr. Andy Nowak, who lead our residency program, which is the best residency program in the world, and are here today to talk to us about evaluations, which is something that we're committing for the year to work on. So I see folks from other departments as well, which is fantastic. And with no further ado, Kate and Andy.
All right, so I will say a huge thank you to Noelle and Savannah for inviting us today to this amazing PEAC session to be able to talk about evaluations, and to Noelle for sharing the most amazing picture of Andy and I on the meeting invitation. I will say it's created some text conversations, and I am super excited to hope that we can live up to that image. Andy will be joining me here in a moment, and so we will get started. So, evaluation revolution, be part of the change, and what we're asking for is change today, because evaluations are so critical to what we do in pediatric education, both from the medical student, the resident, and the fellow perspective. And it's imperative for us to have meaningful evaluations and to be able to meet the trainees' needs, but also to be able to meet our needs as faculty as we think about those reciprocal evaluations for promotion. So we'll talk a little bit about the characteristics of effective written evaluations. We'll discuss some common challenges, most of those being time, and we'll learn to apply some of the tools in a timely manner that will allow you to complete evaluations, we hope, within minutes, instead of them being an onerous piece that hangs over us as faculty. So why do we talk about written evaluations? This is what we use in our clinical competency committee. So a committee that is led by the amazing Amber Hoffman in pediatric hospital medicine to help us as we evaluate trainees, residents in this example, and their clinical competency towards promotion, towards graduation. We weigh heavily on the evaluative comments that you all give us and the evaluations themselves in the numeric format. So we're going to talk a little bit about those milestone form levels today and why it's so important to read the comments and try to evaluate holistically. And then we'll talk a little bit about the formative feedback as your holistic impression of the learner. And then faculty rarely receive this training. And so we are so grateful today to be able to come and talk about this as a group of educators that are interested about how we continue to propel medical education in Children's Hospital of Pittsburgh. So competency-based medical education, that medical education that all of us perform on a daily basis, it's focused on the outcomes, the doing in medicine. It emphasizes abilities. And so again, we want to be strength focused or strength based as we look at evaluations. We want to be learner centered. Each learner comes to us with different experiences across the continuum in medical education. And as we continue to holistically review evaluations, which we're doing right now, we look for learners that have had a broad clinical exposure that gets them to residency here. But that is varied. And so being learner centered, assessing where that learner is and where they're starting, and then giving them goals and working with them on goals for clinical progression. It allows us to give them formative feedback. So if we know where a trainee is supposed to be getting in their competency-based medical education, we're able to help them craft goals, and we're able to give them feedback on those goals along the way. So this is one thing that I will say trainees talk to us a lot about. And so these narrative or profession evaluations, that they're a good teacher in conference. So how could we make that competency based? So Alexa led a challenging care conference with tremendous sensitivity to blank and was successful in completing the conference in a patient-centered way. So we all do this. I do this every day. Gosh, that was a great presentation. That's not feedback for a learner, verbally, and definitely not in a written format. And so thinking about how we can take that less effective feedback and make it into the most high yield evaluation in a time sensitive way. So focusing on specific behaviors, instead of saying someone was unprofessional or that they, in a broad sense, didn't meet a goal that you had for them, recognizing that it is so much more helpful to say that they were often late for rounds, which led to concerns around professional engagement. So those are examples. They're late for rounds, they're not on time for sign out, they haven't prepared for sign out. Those are behaviors that can be unprofessional, but gosh, it is so much more helpful when we're meeting with trainees to be able to give them that specific feedback about the behavior that they're exhibiting, not just this global recommendation. And then someone seemed to know her patients well. So all of our trainees should know their patients well. And so what specific examples are you reflecting on there? So for the patient admitted overnight with croup, Sam effectively and efficiently worked with the patient and family to gather details from the history and physical exam that allowed him or her to provide appropriate medical care and interventions overnight. So those pieces allow us to say, gosh, they are doing a great job at gathering that history, and they're still working on their assessment and plan. So one of the other attributes to effective written evaluations is that they are timely and expected. And I want to shout out our PHM colleagues because they do an amazing job at sitting down with trainees and having Feedback Friday. And so really thinking about how, as challenging as it may be, to sit down and have that in-person feedback, it is so imperative to be able to drive behavioral change. So nothing that is written in evaluations should be written in evaluations without it being discussed with the learner. In person with the verbal feedback. And so this is something that I will say in the past, we have had challenges with trainees getting evaluations in their program director meetings that had never been discussed and that hadn't been shared with them because they are cohorted within MedHub. And so it is always important, if you are struggling with how to sit down and provide feedback to a trainee that may be perceived as not positive or more growth mindset, and you're wondering how you could do it, please reach out to Andy and I. We would always be happy to be part of this conversation, but it is important for that to be delivered from you, the trainer or educator, to the learner in a bidirectional way with verbal feedback. If that can happen in a timely manner, that is always best. And then providing them recommendations for improvement. We know that trainees at this level have been training for 20 plus years. They are used to getting feedback. Many of them crave ways that they can get better. So just telling someone that they're not doing a great job at obtaining that full history, how can they think about that more? Is it a medical knowledge gap that they weren't able to provide the full history, or was it just that it was time? How can we think about giving them skills or giving them opportunities to gain skills for improvement? And it includes agreed upon next steps. And so How would you recommend, if there's something that you need us to be involved in? I see Katie Pollock on the call also, who's amazing as a program director working with trainees on areas to further develop their skills. So reaching out to one of the program directors to partner with us about creating educational plans for trainees. We are always happy to be part of that coaching plan. This does not need to lie completely with you, but we need to be brought in to the levels of concern. Those concerns need to be discussed with a trainee, and we can then create and help you create those next steps. I will say, as we think about evaluations, one thing that Andy and I have talked a lot with our trainees about is that they're not doing evaluations either. And so we are talking with the residents about the importance of completing their evaluations of you all and their evaluations of each other, and those peer evaluations as being critically important. They struggle to give negative or perceived negative feedback. And so we are working with them on the importance of that as we continue to grow and develop skill sets in some of our trainees, that we have to be honest, it needs to be timely, it needs to be in person, and we need to be part of that plan as program leadership. So quality of written feedback. So I think it's important to think about the quality of the written feedback that we're providing. Multiple studies have shown shortcomings in written evaluation. So looking at more basic skills, and all the way to using engendered terms, and differences in narrative comments by gender and by URIM status. This is something that we see in letters of recommendation, and we definitely see in evaluations. And it is important for us to be thoughtful that our female residents shouldn't be discussed with different terms and more socially focused terms than our male trainees. All of them have outstanding clinical skills, and so focusing on those behaviors and those clinical skills is going to be how we provide the most uniform evaluations that are the most helpful for our trainees. I'm going to turn the floor over to Andy for the next portion.
Okay, and we're going to actually physically turn. Oh, well.
Here we go.
Here we go. Here we
We're
go.
playing musical chairs, everybody. We're playing musical chairs.
Here we go. Okay. So for the next couple of slides, what we'd really like to do is talk a little bit about the evaluations and the material themselves. We use, as Kate said, milestones-based evaluations, which are competency-based evaluations. And one thing I really want folks to do is to recognize that running through an evaluation and clicking 5 is really not an appropriate way to approach these evaluations. This is the actual language of our evaluations in systems-based practice around coordination of care and then community and population health. And when you look at the number 1 level, the novice level, where we expect interns to come on board with, does not recognize other members of the interdisciplinary team as being important. We have a lot of interns who are farther down the road, but I just want to make you look at the number 5 statement, the level 5, coordinates interprofessional patient-centered care among different disciplines and specialties, assists family in navigating care, coaches others in interprofessional patient-centered care coordination. We do have an occasional graduating senior that's there, but I want to recognize that not everybody is there, and especially our interns often do not have the opportunity to be the coach and do not do the coordination. And so really, please read the anchors. It's a critical piece for us. If you flip down to the next systems-based practice, adapting practice to provide for the needs of and reduce health disparities in a specific population, advocating at the local, regional, or national level. A lot of our trainees are not there. And when you think about yourself, I might not think about myself as being there either. So when you think about these, what we really encourage you to do, please read the anchors in the evaluations because it's hugely helpful to get the specific language. So let's think about a new intern, for example. And if you've been working with our interns, we're really happy with them, but Our interns have the normal spread of clinical skills that you're going to see in trainees who come to any program. And so let's look at this diagnostic evaluation. So if you look at what an intern might come in with, listing basic evaluations for common diagnoses with some prompting and reporting results of diagnostic studies, most of them are there. Many of them are able to reach that level 2, recommending a broad evaluation based on an unfocused differential. And some really good interns may be at level 3. But if we go to level 5, which is really even above a graduation assumption from the ACGME, that's educating others about risks, benefits, indications, and alternatives to guide diagnostic thinking, teaching others to interpret clinically significant results and consider study limitations. Reaching all of that as an intern is really, really challenging to do. And we recognize that not all of our senior residents will be at that level. So we really just want to let folks know, read these anchors along the way, because they're very much going to help you figure out what the right thing to do in terms of the evaluation. Checking all 5s really does not help the trainee, especially when we come to try to help them with coaching or even remediation. And then when you look at a graduating resident, just look upon this, look at the level 5 here, called upon by others to consult in cases of complex ethical dilemmas, identifies and seeks to address system-based factors. Every now and then on a rotation that has professionalism 2 on it, someone will check 5 on there. I don't know any of our residents who meet the level 5 in this category. So please, please, please read the diagnostic anchors.
And I would just say, we are trying very hard as a program not to give you too many anchors in your evaluations. We have gone back into our evaluations over the last year, pulled milestone language off of evaluations, added written options there, because we really recognize that to read the evaluation or the milestone language, it takes more time. And to get rich evaluation data, we needed to pull some of those off. So you should see that with new evaluations, you have less anchors to evaluate on, trying to really drill down and allow you to read those verbal prompts or written prompts so that you can provide the most accurate milestone scoring.
So moving forward, we really, as part of this training, though, want to give you some tools. And the tools and frameworks are very, very important. We recognize that we have a lot of folks who are innately great at evaluations, and that's lovely. But giving a tool or a framework to begin your evaluation with helps to reduce that cognitive load. It's going to help you get started, which I think is really important. And it promotes specific and really, really well-validated feedback skills that are going to focus on competencies along the way, because we always want to describe the behavior and make the evaluation behavior-centered and not learner-centered. So there are lots and lots of different ways to do this. There are keep, start, stop. There is goal-oriented evaluations, competency-based domains, Prime Plus. There are a large number of tools out there that you can use routinely. And regardless of the tool, what we really want you to do is to have a very brief assessment, specific examples, and then really acknowledge whether you provided this feedback to the learner. As Kate said, one of the hardest tasks we have is a more challenging evaluation where the learner never heard about it. And you can certainly, if you've done goals and objectives with the learner, even describe how they improved or implemented those goals and objectives during the course of their clinical rotation with you. We are going to focus in our program, though, on a keep, stop, start model. And this is something, kudos to Erica Freeling, who really introduced this to the residency program. The reason we love it is it's short, it's memorable, and it gives you a great framework to describe your evaluations. Keep, start, stop is very simple. What are they doing well? What are those things that you really want to highlight? Keep doing this where they have showed progression. Jane did an amazing job this week of communication with families at the bedside. It is a strength area for her in her practice. Things that they need to start doing. This is really one of my favorites, because this is how do you get to the next level. Jane was superb at communicating with families at the bedside. She should start really being rigorous about having an absence of jargon and patient-centered language at the bedside. And then stop are things that really are important for that trainee to try to get rid of. That may be the same thing I just mentioned. The trainee is really using a lot of jargon at the bedside. That's not good for families. They should really try to stop doing that. Or, the trainee is spending an hour and a half on documentation for each of the notes. I counseled them on this. They really should seek out coaching from the residency or their senior about efficiency and documentation. They need to get faster with that. So those are the general framework of how we think this through in order to help you with your evaluative material. So here's a good example of this. Continue your educational leadership of the team and efficiency our rounds. You help the team meet their stated goal of finishing rounds by 11:30, but start including that bedside nurse on rounds for each patient moving forward. Very frequently, you will find there's nothing you want them to absolutely stop. I would say that if you find something they should stop doing, that's a great reason to make sure you give that in-person feedback. Because when you want to modify a behavior to have them stop doing it, it's really, really critical for them to hear that up front. So goal-oriented evaluations is another way to go through this. I think that the PHM folks combine keep, stop, start, and goal-oriented evaluations a lot in my experience and do it beautifully. So this really requires that you elicit goals. I will say it's a little easier to do on a 1-week rotation, but I have absolutely seen my colleagues in emergency medicine and general academic P's do this as well when they're working a single 4 or 6 or 8 hour shift with a trainee. And it can really just reflect where the trainee is going and what they're working on as well.
And for those of you that are on subspecialty teams or rounding with a subspecialty inpatient service, just so you know, Monday mornings, we've canceled morning report so that teams can form shared expectations of the week. They can set goals together as a team. They can set individual learning goals. And that's really a wonderful time that if you have available to join the team, to be a part of those goal setting experiences. Your leadership would be very valued there. And it also gives you an insight into what the trainees are working on in that given week.
Another form of evaluation is using competency-based evaluation, which is really to just go back to the evaluative anchors we provided you in our competency-based evaluations and use them as the focus for your evaluative material. And this is really simply just reflecting, as you can see, on the 6 core domains of competence as defined by the ACGME. And you can really use those explicitly if you've just finished going through those anchors, maybe reflect a couple of them. And then finally, the Prime Plus tool. I'm not going to spend a lot of time on this. It's just kind of helps you to recognize how many tools are out there. This is one using the Prime Plus algorithm to talk about professionalism, the RHIME spectrum, which we're all familiar with, and then kind of something to work on. Any of these will work, but when you hear us coming around to your divisions to do some specific teaching, we're going to focus on keep, stop, start, because we think it's memorable, it's easily implementable, and you can get it done in 2 or 3 sentences in the average evaluation without it. All right.
All right, we'd love for folks to practice writing an evaluation. Maybe it's a learner that you're working with currently. Maybe it's a learner that you worked with in a prior experience. We'd love you to utilize one of those frameworks. So either keep, stop, start, goal-based evaluations, competency-based evaluations, or the Prime Plus model. Again, I am with Andy. I think keep, stop, start is the most easily memorable, and it actually provides the most high yield feedback. So if you're looking for one to trial, that would be the one I would recommend. We're going to take a couple of minutes, just give you time to work through an evaluation. I'm going to then have us come back at 12:45. We're going to ask 2 brave people on the call. I love it when people volunteer, but I am happy to call on folks to share that evaluation, why you chose. Oh man, people are dropping like flies with the activity. Why you chose that evaluation format, and how it could be, like, how we could use that evaluation and how it could be improved. We are going to try to make this timely for you all. Again, we recognize that the biggest barrier to doing feedback is it's challenging to provide growth focused feedback because we are pediatricians, and it is not natural for us to talk about the things where people don't have strength, but it's our job as educators to really build up those areas. The second part is that time is a constraint, and it's hard for us to find time to do those evaluations. We're going to give you 5 minutes right now to work on an evaluation. We'll then come back. We'll ask 2 people to share, and then we will have one closing activity.
And we're back.
And as promised, Andy and I are from a beautiful beach location that Savannah has put us on. And we're excited to hear about evaluations. Amazing. I invite anyone who'd like to join Dr. Choi with her camera on and Noelle, Dr. Spears with her camera on. We'd love to see smiling faces as we work through this in a small group. Dr. Spears, yes, ma'am.
Wow, she put it in the chat.
Well, I did. I was thinking about a student I worked with last night, and was a newer student, not one of our residents, and was presenting back and forth like the HPI, then the past medical, then a part of the HPI, then a part of the physical exam, then a part of the assessment. And so I gave her the feedback. I think I use this keep, stop, start, but I find that in writing it down, I realized that I didn't tell her to stop anything last night, but the stop is sort of the opposite of the start. I could think of it that way. So how do you separate them?
I think that it's, you know, we are pediatricians, so we want to be gentle in our feedback. And I find myself doing that at times as well. And I think this is it's okay if those two are in opposition to each other. Your start is technically just the opposite of your start, your stop. But I also think your start is not, it's more specific about how they can improve. So it's really saying, you didn't say stop presenting me scattered information, which a learner may be like, oh God, but you did say, why did you present it in a really structured way like this, HPI PM? So that is the opposite, but in some ways it's a much better plan for them just saying, stop presenting in disorganized fashion. So I'm completely fine with this approach to it.
Yeah, it's almost like taking the growth mindset of stop.
Yes. Right. Okay. Thank you.
Anyone else willing to?
Oh, I think Sylvia's got her hand up.
Oh, Sylvia.
Choi.
Sylvia, go for it.
I had wanted to echo what you had said about how helpful it is to solicit goals from the learners at the beginning of working with them, because that makes doing their evaluation so much easier because you already know what they've identified as being something that they feel like they want to work on. Most people are not picking things they already are fabulous at, because otherwise, why would that be one of their goals? And so in the a week that I recently had with the learners, the one goal they had was to use jargonless communication. So I said that they should keep translating medicalese into English, stop giving specific lab values, and start giving big picture of what those lab values mean.
Oh, Sylvia, that's fantastic. And it's learner focused, right? That's what they're working on. It reflects where they started, something that they could improve upon. And then really that next level, which is giving the growth or the big picture. Can you talk about the forest without talking about the individual trees? Which is a fantastic example. Thank you for sharing.
And those are two good examples of Noelle is on a single shift with a student, uses a keep, stop, start model, and is able to find really useful feedback out of one shift in that model. Sylvia is combining a goal-oriented evaluative style with keep, stop, start. And those two come together really nicely and easily. And I reflected that because I read them in my excellent evaluations for my PHM colleagues all the time. So I think those are really great contrasting examples of what you can do even in a single shift, and also the advantages of that intentional goal setting at the beginning of a longer clinical rotation.
Annie and I want to acknowledge that we are not experts in feedback. You all are experts in feedback also. And so thinking about how things have worked well in feedback in your specific divisions, or is there a specific time that you give verbal feedback? Is there a way that you or someone in your division likes to give feedback that you think is really helpful and time efficient? We'd love to open the floor for our thinking with you all who do this often about how we can continue to elevate feedback.
You can unmute, you can put a suggestion in the chat either way.
One of the things that we've started in endocrinology for our fellows that Canthi brought to us was, we're calling it like our 365 evaluation. So we have our summative evaluations twice a year. I know you guys do them more frequently, right? Because the residents on rotations, but in the moment, I may just have one clinic with a fellow and I may not remember then when I evaluate them 6 months later what it's like. So we actually have like a short kind of Qualtrics form that we would fill out in the moment, that we have a QR code, we can scan it, and we can just, for whatever fellow, kind of fill out sort of what they did well or what things they're working on. And it's also nice then, because if you have some more, hopefully you've discussed it with them, right? If you have anything that's more constructive, it's not necessarily going on their formative evaluation. It's in that kind of in the moment feedback. And that gets shared with them like on a every couple week basis.
Oh, Christine, that's a great idea. And what are you utilizing to gather that data? Like what QR link are you using?
Well, so we're using Qualtrics, which
Okay.
is like a University of Pittsburgh sponsored survey platform, and you can generate QR codes to access that.
Okay, fantastic. That's a great idea. I think,
Casey and then Lang.
yeah, Dr. Pollack.
Thanks, Dr. Watson. I'm going to turn it over to Dr. Miller.
Hi, doctors. I just want to say one thing that I've not, historically, I've had trouble keeping up with my written evaluations. In the last couple of years, what I've started to do is after a week of service, I find 90 minutes on my schedule the following week and just block it. And that is time for me to do my evaluations. I need to preface that by saying I have a schedule in which I can find 90 minutes the week after a week on service, because I don't do service all the time. So some people that might not be feasible for, but I think hopefully most people can find some time in a schedule after a chunk of service to sit down and do them. And that way it's there, it's a good reminder, and it's still relatively fresh if I do it within a week that I've had that experience with the learners. So that's been really successful for me to make sure I get my evaluations done. I mean, we typically are going to have 8 to 10 evaluations to do probably from any given week of service between our daytime team, which includes medical students, interns, and a senior, sometimes a fellow, and then our night team of a senior and an intern. So that I think has worked well for me.
Ben, I think that's a great idea. And given the number of learners you have, is probably appropriate in that 5 to 10 minutes to give that written feedback by the time you're in MedHub in the medical student format. So I think that's a fantastic idea, with being really mindful and trying to put it on your schedule before that schedule fills up the week after, because I imagine that is challenging.
Ling, you had your hand up. Did you want to raise something?
Hey, oh, sorry. I'm having a Teams problem right now. Can you give us some hints or guidance or personal methods in which you might be able to give feedback to a particular trainee who might take the feedback as an offense to their personal traits?
So that is always very, very, very tricky. And what I will sometimes do before that is I will literally go seek out a colleague to practice the things that I'm going to say. I recently did this with a resident who we were going to discuss an improvement plan, and I went to their Bridges mentor to reflect with them and say, here's what I want to get done here. And they were incredibly helpful to help me kind of frame it along the way. None of us like remediation / coaching / improvement because we are all positive people, and it does not feel good, but it's so critical for those trainees to hear. I think what I very much try to do is to separate the behavior that I observed from the trainee themselves. I will almost always observe that I recognize and appreciate the fact that they want to get better. The nice thing is we almost never, ever, ever want somebody to not get better. And if I'm really nervous about it, I will just go to trusted colleagues. All of us have superstar educators in our division, and a lot of them are on this call that can serve as sounding boards. And Sylvia put it in there, role play. We love it for a reason. It's effective. And doing a little bit of pregame to get the words and the script working is, I think, an important piece. It also allows you to kind of get those thoughts out loud and make sure they don't sound personal, like a personal observation. They do sound behavior-based. And then recognize it just gets challenging along the way. Judy Squires, you raised your hand.
Oh gosh, now am I unmuted? Sorry, this is a new PAX. Thank you for letting a non-pediatrician be here. Okay, so not to generalize the junior residents, but there is clearly this sort of mindset shift of less emphasis on work, more emphasis on activities outside of work, and sometimes with attitudes that might come off as lazy, not a team player, sometimes unprofessional. So can you maybe walk me through some of the things you might say to a trainee who is performing well, but just is giving an attitude of they don't like sort of care, please? And thank you.
Yeah, I think that is a good one, Judy, to talk through. So I typically take it back to the large group. So residents are recruited here because we believe they're going to be great team players. And we think that they have a lot to offer to the team. And so thinking about how their focus on time outside of the hospital may impact that larger team, and what those asks are to their colleagues, and what the impacts may be for the patients that they're seeing is typically where I go with concerns about that. We have definitely had challenging conversations where our expectations and a trainee's expectations are different. And so we try to be very clear about what our expectations are from that clinical care delivery perspective now. And we also try, I want to give Ben Miller kudos for this, to help our trainees think about what brings them joy within this hospital, because wellness and balance doesn't only exist with time outside the hospital. And so trying to think about how we can continue to focus on those strength areas within the hospital to balance their expectations of what wellness means and what balance means is something I've tried to adopt more.
And I also think, what you can do is some forced self-reflection. And I'll often share a strength in that situation, Judy, and then, say, hey, you did a really good job leading the team this week. You were pretty focused, but I want to share a piece of feedback with you that might be hard for you to hear. Is it okay if we talk about that? And once I have that permission, what I'll say is, you do all these other great things, but from the outside, it appeared sometimes that, when you hit the 5 o'clock mark, that you were done and you were ready to be out. And that's the perception that some team members got. And then I just allow them to reflect, because no one's a villain in their own movie, right? And so I'll say, what do you think about that? Does that match up with kind of how you were feeling it? What do you think may have led to that? And folks, I think it first of all, it reduces the stakes a little bit to say, this is what the outside was. It allows them, for me to not say, you were leaving too early. It allows me to say, some people perceive that, you weren't committed to the team because of this observed behavior. What do you think about that? Because it also will sometimes give them the ability to say, that's not who I am. But I guess maybe it could seem that way because of blank. Which is not running away from it. And it is an ability for them to hear it and then also have their day in court a little bit, which is what learners want. So it's 12:59, so I'm going to leave you with one last thing. Often it will
go to the next slide, just our closing.
Right. Thank you.
I just want to leave you with some charges moving forward. Setting the stage for a great week by gaining trainee-driven goals on Monday. I'm going to call this Mission Monday to be a name that we can give to those goal-setting sessions, and provide a brief midweek feedback if you feel as though residents are not able to meet those goals, or if things are going awry where gosh, you need them to make a course correction midweek to be able to meet that goal by Friday, please give them verbal feedback on Wednesday. That doesn't need to be written, but really is helpful if it is verbal. Verbal and written feedback on Fridays, or has been recommended possibly the following week. And then we really are going to encourage you to use Keep, Stop, Start as our format for the written evaluations. We think they can happen in a timely manner, and will give you time back in your weeks and trainees really informative feedback.
The last piece I just want to bring up is frequently a faculty member will say to me, I gave them feedback. I talked to them about this, and the resident says, well, I never heard anything about this. I will just quote the great philosopher Stephanie Buck-Dewar, former program director, who used a little tool that I've adapted, which is to just literally say, here is feedback. And as silly as that tool is, it is incredibly effective at helping the learner anchor what you're saying to them as feedback. That, just labeling, here's some feedback. You did really well there. You need to keep doing this. That was some feedback, is something when I started practicing it, really helped learners, even on my teams, recognize that what I was giving them was actually the feedback there. And I think that's critical, because they will often think of it as informal conversation, not feedback, when you're clearly giving them feedback on performance. So thank you, everybody, for joining. We will be seeing you in your individual divisions over the next few months to talk about this with them. And we appreciate your dedication to education in our department.
Thank you, thank you, thank you for the feedback. We're super excited to see all the evaluations coming in.
Okay, see y'all.
Make it a great Wednesday, everybody.